Welcome to the Medical Report. Our discussion today is going to be surgery of the shoulder. And to discuss this with us today is Dr. Adrienne Towsen. Dr. Towsen is a board-certified orthopedic surgeon with a fellowship training in sports medicine, and she is associated with the Chester County Orthopedic Group. So we appreciate your coming and spending some time with us. We'd like to learn a little bit more about shoulder pathology and the things that, injuries that happen. We have a group of athletes here, you know, in Hershey's Mill. So I'm sure they'll all want to know a little bit about, first of all, the anatomy of the shoulder and what things can happen.
Great. Well, I'd love to be able to explain that. I do have a model with me here today that we can use a little bit, but the most important group of muscles in the shoulder is referred to as the rotator cuff. And many people have heard of the rotator cuff, perhaps injured the rotator cuff, and it's an important group of muscles in the shoulder. In this model, if we could take just a brief look, the humerus or the arm bone is right here. The shoulder blade is on top. The socket is sort of buried down deep inside. The rotator cuff is represented by this area here, this soft tissue muscle, and it's not clearly defined in this model, but the muscle is attached to the bone by a tendon. The rotator cuff is actually a group of 4 muscles, and those muscles function together to position the arm in space, to raise the arm up overhead, out to the side, reach behind your back. So I often refer to it as the workhorse of the shoulder. It's really an important group of muscles, and therefore it's very susceptible to injury, both overuse injuries and traumatic injuries.
Now what our audience is looking at here is the front part of the shoulder, and that's the clavicle going off to one side. Perhaps you could rotate it around to show them the rear aspect.
Certainly. Yeah. So here's the posterior or back view of the shoulder. The large bone here is the scapula or the shoulder blade, which has many irregular prominences that are muscle attachments. And as Dr. McCabe pointed out, the clavicle or collarbone is right here. And then the collarbone makes a joint with the shoulder blade, which is up top here, and that is often an arthritic area for many people. The actual shoulder joint is deeper down inside, and if I can pull the humerus or the arm bone away a little bit, the socket is down deeper inside, which is called the glenoid, and that's the shoulder joint itself.
So this shoulder has a little ball on it that rotates in that socket, is that right?
It does. It's very much like a hip joint in that it is a ball and socket joint.
Now, what are some of the most common disorders that can occur with the shoulder, particularly in our age group here that you're talking with?
The most common thing that we will see by far is a rotator cuff problem of some sort. And there's a wide spectrum of rotator cuff pathology or problems, including just a tendinitis, which would be an inflammation and overuse of the tendon. Often that is accompanied by a bursitis, which is an inflammatory response in some tissue that sits above the tendon in this space. And then very commonly we are actually dealing with rotator cuff tears as well. And what that means is that the tendon attachment, where the muscle attaches to the bone, actually tears away from the bone, and there are variations of that. Certainly we also see arthritis, as I mentioned earlier, in the joint between the collarbone and the shoulder blade, also sometimes deeper down into the shoulder joint, but without question, by far the most common thing that I'm treating on a daily basis in many age groups in the shoulder would be rotator cuff pathology of some sort.
So in this age group here, though, it's not unique to older people, though. It can be in the younger age group as well.
That is correct.
Yeah. Okay. Now, what is the overall incidence of some shoulder pathology, would you say, in the general population? I realizing there's certain subsets, but...
Right.
Yeah.
It's actually quite high and quite poorly defined, because many of the problems that we deal with routinely, including the rotator cuff, present in such different ways, and many people can not be particularly symptomatic from a chronic rotator cuff problem. So it's documented in our literature anywhere from 5 to even 40% of the general population across age groups could be dealing with a full thickness or complete rotator cuff tear. And then other issues, including the tendinitis that I mentioned, and more overuse injuries, maybe less severe injuries, can be an even higher percentage than that in the general population. So really in a lot of the different places you read, it's poorly defined. It will often say the incidence is unknown because there is such a wide variation of problems considered rotator cuff issues, and it's basically what I would tell you is it's incredibly common. It is it fills our office every day, anywhere from tendinitis to tears.
Now, what are some of the causes of these different disorders that you've discussed? Tendinitis, bursitis, rotator cuff tear, and so forth.
Well, very often with tendinitis and bursitis, it is more of an overuse problem where just sometimes with routine daily activities, people can develop these issues. Sometimes with sports or recreational type activities that might be a little above what your everyday activity is, or even exercise that you're doing maybe with some light weightlifting or things that involve repetitive motions with the shoulder can cause a tendinitis or a bursitis. We will sometimes see tears caused by more traumatic events. People can have falls or lift something, go to lift something heavy and it falls, and that may cause an actual tear in the tendon. And lastly, just degeneration of the tendon over time, which is very, very common as we get into the 5th and 6th and 7th decades. It's more of a wear and tear phenomenon just with aging that can cause either a tendon to partially tear or completely tear without a traumatic injury.
Now, we have a lot of people in this community who play tennis and also play a lot of golf.
Yes.
These are the two major sports. I don't think there's any football players or baseball players still active, but is there anything about either of those activities that people should be very careful about?
Both of those activities certainly do put stress on the shoulder, and I will find many golfers and tennis players commonly with rotator cuff issues, including what we've discussed already, the tendinitis, and occasionally a tear even from that type of activity. Golfers often can accommodate for a rotator cuff problem pretty well. Sometimes it will depend on which side it is, which arm it is, but it's more the repetitive nature than anything else of these sports, just like other more routine activities that cause wear and tear over time. Certainly an overhead serve and some of the other more aggressive tennis serves or moves would potentially cause a problem with the rotator cuff, and really it just comes down to the repetitive nature of it. So one thing with tennis, for example, we'll say if you can, play doubles or do something that might, lessen your need to be hitting quite as often, that's one way to accommodate it if you're having a problem with the rotator cuff.
That's very good. Now, doing the dishes every night's not going to do it, right?
No.
Okay. We have, certainly, there's got to be some diagnostic clues that tell you just exactly what's happening. Could you tell us a little bit about some of the symptoms that people would experience?
Absolutely. The most common symptom that people will present with in the office is pain. There is generalized pain around the shoulder, but more often than not, the pain is actually down into the upper arm. And very commonly, people will be surprised to know that the pain in their arm is actually related to a problem that's deeper in their shoulder. So pain is a common presenting symptom, again, often in the arm. People will have pain at night, which is very common. Sometimes people are able to get through some daily activities reasonably well, but when they lay down in bed, particularly if they like to sleep on that side, it can be very difficult. And there are certain very characteristic limitations with range of motion, particularly raising the arm up overhead, reaching out to the side. Rotational motion, such as reaching behind you to pull up a pair of slacks or get something out of the back seat of the car, things like that will be very difficult for people, either with with a tendinitis or with a tear. So there are limitations with range of motion. There's pain. very commonly night pain, and people will have varying degrees of weakness. There will be limitations with the ability to do overhead activities often and do anything that requires any type of a heavy lifting or sustained position overhead.
So sometimes the pain then will radiate right down the arm.
Absolutely, it can. And I have some patients where it will radiate down beyond the elbow. It's very common, and really across the board we see it in the upper arm. That's always there. And sometimes symptoms will come even further down the arm into the hand.
So when you do a physical examination of someone with one of these things, are you looking for areas of local tenderness or restriction of motion, or what are you looking for when you do the examination?
Mm-hmm. There can be areas of local tenderness up around the shoulder itself, near this area here and part of the shoulder blade, where sometimes people will have a bone spur that might cause some impingement on that tendon and may have contributed to the tendinitis or the tear. But more importantly with the physical exam, we're looking for limitations in range of motion, looking for certain positions that we can put the shoulder in that will elicit pain that are characteristic of a rotator cuff tear. For example, raising the arm completely up overhead or rotating it in certain positions will cause contact between these two bones here, the humerus and the part of the shoulder blade, and that will cause pain. So we have certain provocative tests that are very telling. And one of the biggest ways, or one of the easiest ways to clinically try to determine whether the tendon might be torn or not, is by weakness. There are a couple of positions that we can put the arm in that really isolate the rotator cuff, and if people are weak just to physical testing, just to my resistance, it can be a very telling sign about the possibility of a tear.
Yeah. So that the diagnosis that distinguishes a tear from simple inflammation of an area or by different maneuvers that you will do to demonstrate that. Is that right?
Yes.
That's oftentimes confused, and so
Yes.
that was the reason I asked that question. Now, if you're in your mind not certain, what diagnostic studies would you perform to help you with the diagnosis?
The absolute best study to diagnose a rotator cuff tear or any variation of rotator cuff pathology is an MRI scan. We can get all the information that we need generally from an MRI because it's a great study to look at soft tissues. We can do simple x-rays, and that will certainly show the bones and the joint relationships, and they can be helpful, but in order to fully image the rotator cuff and be able to tell for sure whether it's torn or not, or whether it's inflamed, and then exactly the degree of the tear, because there are small tears, medium-sized tears, large tears, and so on and so forth. An MRI scan is the best study, absolutely.
And that shows you if a muscle is actually torn off. You can actually see that on the MRI.
Yeah, absolutely, yes.
Whereas you can't do that with a standard X-ray.
That's true.
Which is a big distinction. To the people will often say, I had my shoulder X-rayed, didn't see anything.
Right, correct.
That's good. Now, I think one of the things we like to kind of summarize what we've talked about here is you have a category of injuries to the shoulder, the most common of which you see is the rotator cuff tear. Is that correct?
Yes, correct.
And so we're going to wind up this particular session with letting Dr. Towsen kind of go on a freelance here about what people come in to see her about and what is the most common thing that people do to cause it, and what are the most frequent complaints. Could you do that for us?
Yes, sure, absolutely. In taking care of primarily shoulder injuries for the past 4 to 5 years, again, the most common thing I see in the office are people with injuries to their rotator cuff. I saw about 20 patients in my office this morning, and 15 of them were rotator cuff problems. It is really a very, I consider it an epidemic sometimes, because it really is just the most common thing that I see. There are other tendons in the shoulder that can become inflamed. For example, the biceps tendon, which this model unfortunately doesn't show you very well. It travels down the front of the shoulder into where the bicep muscle would be here in the front of the upper arm. And it actually lays right under the rotator cuff tendon, and it's pretty common for people to have associated biceps tendinitis if they have a rotator cuff problem, or they might have an isolated issue with the bicep. It's possible to rupture or tear that tendon as well, but typically that's far less symptomatic, and we often don't really have to do anything for that, but it's an injury that we often, or that we will see as well. It is not as common, but I certainly do see a fair amount of shoulder arthritis in the office, and I'm talking, when I say shoulder joint arthritis, that's the deeper joint, the shoulder joint itself, deeper down inside this model. And unlike the hip and knee, which we certainly treat a lot of arthritic conditions there, many people can tolerate a good bit of shoulder arthritis before they become very symptomatic from it. So even though we can do joint replacement for the shoulder, and it's very successful just like with the knee, it's often not as necessary. Far more common to need to do something to fix a rotator cuff tendon.
Well, that's a very interesting discussion, and please stay with us because we're going to talk in the next session a little bit about the therapy. So stay tuned.